just look at some of the complications. We already, looked at the history, how the nail came through. This is the initial Nancy manual, which was then translated into English. So if you're interested, if you're going to do more nailing, I would recommend that you read this. I don't think that I've seen an online copy, though, probably it may be floating around, but this is a good book to invest in. 10 mistakes to avoid. First is fracture selection. So I'll show you a case of a 12-year-old boy who was wrestling, had a fall, he weighs 35 kilograms, and this is a fracture. So when you have a long oblique or spiral fracture or a comminuted or segmental fracture, these are all called length unstable fractures. So with length unstable fracture, what you expect is a little bit of shortening. So this patient had this 3.5 millimeter nails. It looked good on table. Shortening was acceptable. Anything up to 2 centimeters is acceptable because you do expect a little bit of lengthening afterwards. 3 weeks later, however, the patient had 4 centimeters of shortening and the nail had backed out. So this is not acceptable. If you leave it like this, the patient is going to have a limp. You'll have to lengthen him later on. So right now, at 3 weeks, the fracture is not healed, so you've got to do something to restore the length, and there are several options. In this patient, we used a plate to stretch and fix it. The other options are to use an IFICS as shown here. There are also these end caps that you can put at the end of the nails. Personally, I've never used these, but they say that that can prevent the nail back off. And my concern is that if there is collapse at the fracture site, it may penetrate the proximal aspect of the femur. So I don't like to force the nail to stay in. I'd rather have it back out and then do something, but prevent it from growing more proximal. These are the end caps. So the ideal indications are length stable fractures, diaphyseal fractures, and for femur fractures, weight less than 50 or age less than 11. The same criteria for femur fractures do not apply in the tibia elastic nailing. For tibia, there has been no difference based on age or heavier or lighter patients, but for the femur, there is a difference. You won't try and avoid it for heavier and older patients. And this is one of our paper here from India comparing the elastic nail with IFICS versus bridge plating. So this is what I was showing, but they would do it right from the outset before they collapsed. They would put elastic nails, put an IFICS on, compare it with bridge plating, and there were no significant differences. So what are the risk factors for displacement? So typically if you use it at either end, because these nails are meant for diaphyseal fractures, if you try to use it for proximal fractures like subtroch, or for distal fractures, or if you use it for comminuted fractures, then you're going to have some issues. So we looked at our experience with subtroch and supracondylar femur fractures, and what we found is of 36 subtroch fractures, we had a 22% complication rate, which is a little bit higher than what we would get with the normal diaphyseal fractures. We required 4 repositioning of the nails, 2 malunion, nail irritation, and limb length discrepancy. For the supracondylar femur fractures, how do you nail these ones? These are nailed in an antegrade fashion. That means the nails, they come from the trochanter. You put 2 nails, one is an S-shaped nail. The other one is also S-shaped, but when you rotate it, once it crosses a fracture, it becomes a C-shaped. You put a C-shaped, and once you rotate, it becomes an S-shaped nail. And so this also works, but there is a significant high complication rate as well. We had 2 nails which had some irritation over the greater trochanter, had to be removed early, and then infection. As far as the technique is concerned, you want to make sure that the nails have maximum spread at the fracture site, and it crosses only twice in your construct, proximal and distal, as you can see in this left side X-ray. When it comes to radius and ulna, the tip of the nail should be pointing to the opposite bone, so radius nail should point towards the ulna. And the idea is to maintain the interosseous space. So if you have both tips pointing towards each other, it can maintain it. So this is an example of an improper technique, because you can look at all the arrows where the nails are crossing each other. That's a corkscrewing or a sign of struggle. Here there is distraction, improper reduction, and then mismatched nails. Both nails have to be same size. Each nail should be 40% of the canal diameter for radius and ulna nail. Each nail should be 2/3 of the canal diameter. Here is a case of a 13-year-old with a right radius ulna fracture. And if you look at the canal here, it's pretty small. It's about less than 2 millimeters, which is, there was a recent study that came out, more than 500 patients, and measured the medullary canal, and about 5% of the patient had canal size which was less than 2, which is very narrow. And if you try to jam a nail here, you can see here it's less than 2, 1.8. We pushed the nail and jammed the nail, and the nail got stuck into the canal. And in further pounding, and you can see there was distraction or epiphyseal lysis of the physis. So that's another thing, is don't try to force the nail. If the nail cannot advance, then you have few options. You can wait a little bit, give it some time for relaxation. You can withdraw, rotate, and reinsert it. You can decrease the size of the nail, or you can cut the nail short. You don't have to go all the way. So so these are the options that you have. And the narrowest part of the ulna is in the distal end. So just make sure when you're putting the nail at the end part, you may distract the fracture because it's the narrowest part. So be careful and just check the fracture site once your nail is through. The nail material, titanium and stainless steel, are the two materials that we use. The elastic modulus of titanium is half. It's easy to insert a titanium nail. It takes more force to insert a stainless steel nail, but stainless steel nail does give a little bit more rigidity to the construct, so your malunion rates may decrease, as shown by this paper where the malunion was higher with the titanium nail. But the stainless steel nails do cause some comminution because it takes more force to insert it. So here is an example of comminution with a stainless steel nail. If you do an open reduction, you follow the patients closely. Here is an example of a radius ulna that was treated with open reduction, and it went for non-union and then had a fall. And here your option is you remove the nails, you put a plate on like done in this case, or you can bend the nails inside too and convert them into a stable construct, and that can heal. Here is an example of a tibia ORIF which led to non-union and a refracture. So anytime you open the fracture, there is a risk of late union or non-union. Floating injuries, that is injuries of the femur and the tibia, they are more prone to complications as well. Here is an example of femur and tibia nailing. Everything looks anatomic, but at the end you can see there is valgus and a little bit of length issues as well in the patient. When we did the removal of the nails, we did find that there was a growth arrest over the lateral aspect. I don't know if it was iatrogenic. I don't know whether it happened the time of the injury. The patient required further surgery with the lysis of the growth of the bar and then growth modulation, and did end up with an acceptable alignment at maturity. Here is another example of a floating elbow where, floating knee, where there is a lengthening and a valgus deformity once everything is healed. And so we ended up putting this guided growth to correct the deformity first, followed by closure of the physis so that we can maintain the length. And this is at skeletal maturity. So if you know what the issues are, that means valgus is common with floating joint injuries and length issues as well, then you can address it, or you can inform the family that might need more surgeries down the road. When it comes to iatrogenic fractures, you want to be careful how you insert the nails. You can penetrate the other side, or you can get fracture at the insertion site as seen here. So you need to be careful. Just make sure you don't make bigger holes, or don't make too many holes. One hole of adequate size is enough, and then you can try to put your nail through. Here is an 11-year-old female that had an unstable, length unstable fracture, and we tried to nail it. We tried to start with the retrograde nail, then we came with another antegrade nail. There was combination. It made the fracture really unstable. So what do you do now? None of the nails are across a fracture site. You're 1 hour in the case, and you have 3 big fragments, and we had to change the plan here. We went from, we gave up nailing, and we went to plating instead. We used traditional plating here, and the patient did well. And this is just to show you that, every time you try to do a nail, it doesn't mean that you have to nail it. If you find that you are struggling, or the situation has changed because there is a butterfly fragment that is separated, then you might have to have a plan B, or plate or an IFICS ready to salvage the situation. So just think about it. And here is a case where I walked in the room and the nail was through the fracture site, and I told the resident to show me the lateral view. And here is the lateral view. The nail had missed the distal fragment and had just gone all the way in the proximal fragment. So just make sure that you take orthogonal views when you're using The fluoroscopy, there have been cases of, this is a case of sciatic nerve irritation because the nail there is anteversion of the femoral neck. So if you just keep your nail straight, it's going to penetrate the posterior cortex and go towards the sciatic nerve. So just be aware of how you want to contour the nails and take orthogonal fluoroscopy. Nail prominence is a big issue. It can lead to skin slough infection, osteomyelitis, stiffness, joint swelling. So one of the reasons why the nails were getting this irritation was because the initial recommendation were to bend the nails 90 degrees after insertion, and that led to a lot of series that reported significant entry site irritations, up to 50% in certain series. So what has changed is that the original recommendation, leaving the nails long or bending them 90 degrees, we would recommend that you should keep them flush. Don't bend them 90 degrees, and just keep them around the level of the physis, and then we don't see nail irritation as much. And then you can also have a longer nail, not an entry site irritation, but irritation on the opposite side if you leave it longer. Here is an example of a 14-year-old boy with an open fracture. We did antegrade nailing here, but one of the nail was longer. I thought that we are in the bone. I checked it a couple of views, but I was wrong. The distal end of the nail is actually just above the trochlea, and the patient had constant irritation in this area 6 months post-op. We removed the nails anyways at around 6 months, all the nails that we put in. But this patient had more pain, so I took him back to the OR a little bit sooner than I routinely would. And when I checked it, you can see the protruding tip of the nail, and that's exactly where he was hurting. And I took the nail from this side. I took it out, even though I had put it from the top. And here is an example, another patient of mine, 12-year-old. This was the last fluoro shot, and you can see the radius nail is not long, but what happened is that if you are at this point and then you cut the nail, if you impact it, it is going to go further in. So you have to cut the nail at some point. So usually we back out a little bit, then cut, and then impact it, and here I thought I had enough space, so I just cut the nail where it was and impacted the nail, and then post-op, when I took an x-ray, the nail was longer. You can see that the patient did have pain, the patient had irritation, and luckily the patient had another injury the following week for which the patient was going to the OR, had a metacarpal fracture, and so at that time I was able to back out the nail a little bit. So I didn't have to take the patient specifically for this, but I did I backed out the nail, trimmed it, and impacted it, and this is a 2-month follow-up. The patient did well. And lastly, for nail removal, for pathologic fractures, we usually retain the nails. This is for a cyst. Same with OI patients or any pathologic fractures, you don't want to remove the nails. Here's a case of a 13-year-old with a displaced fracture that was treated with elastic nails. The patient came for follow-up 4-month post-op. The fracture he had healed, but the patient had also had a growth spurt. So you can see the tip of the nail is in the bone, and it was difficult to remove the nail, and we left the nail in, even though we did attempt to remove it once. And then the patient came back 4 years later, and then he had another injury, and now he had a fracture right here. Now, if this was a displaced fracture, what would you do? Because he is a candidate for plating, the nail is going to come in your way, and it's very difficult to remove the nail at this point when it has been in the canal for such a long time. That's why we recommend taking the nails out. Now, this patient, fortunately, the fracture wasn't displaced, so we treated him in a cast. It went on to heal, and he did okay. But there is a tip of how to remove the nails is, using the cannula for your suction that you use. You can put it on top of the nail and bend it 90 degrees, or create a little bit of space to put your instrument to extract the nail. But in summary, it's the principle of TENS is based on sound biomechanical principles. The attention to details is important, and complications can happen to anyone. You try and recognize the complication and learn from it so that you can avoid it in future. Thank you.